Okay. Okay. Some of you in the comment section remind me of ना MBBS के दिन जो back benches होते थे ना उनकी याद दिलाते हो. अच्छा, coming back. So sexual development may we need to understand a few things which is very important. So everybody concentrate here. Okay, so sexual development may we need to know when a embryo is formed. Okay, the embryo can be 46XX or it can be 46XY. Okay, what happens in the 46XY? The gonad that develops is the testes. In 46XX, the gonad that develops is the ovary. Right? Remember, in the embryo, in the beginning, till 8 weeks, both the Wolffian duct, okay, and the Mullerian duct, both are present. Okay? And then depending on which sex it is, so this is called the genetic sex. The 46XX or 46XY is the genetic sex. So the genetic sex is going to determine what is the gonadal sex. So the first determinant of sex is the genetic sex. Is it 46XX? Is it 46XY? What happens in the 46XY wala person? In the 46XY wala embryo, there is the Y chromosome. Okay. And on this Y chromosome, on the short arm of the Y chromosome, you have the SRY gene or the sex determining region of the Y chromosome. It's called the SRY gene. Okay, this is the main gene. There are many other genes which we will discuss in some time, but the main determinant कि इसका gonad जो बनेगा, is it going to be the ovary or the testes, is the SRY. If the SRY gene is present, the gonad is going to be the testes. Remember, in the embryo, the gonads are undifferentiated or bipotent till 5 weeks. That means if you do a biopsy of a 5 week embryo and you biopsy the gonad, you will not be able to say कि ये testes है या ovary है. It will look the same. So gonads remain undifferentiated. Weeks. At 5 weeks of gestation, the SRY gene is if it's present, that gonad is going to become the testes. If the SRY gene is absent, it's going to form the ovary, right? So this is what's happening, the first thing that happens. Now let's continue. So let's talk about 8 weeks बचे था. The internal genitalia is bipotent till 8 weeks and the external genitalia is bipotent till 9 weeks. So remember, in the embryo, the gonads are bipotent till 5 weeks. At 5 weeks, it either becomes a 46, the gonads either become the ovary or the testes. Also remember, the internal genitalia are bipotent till 8 weeks. That means both Mullerian duct and Wolffian duct coexist. And the external genitalia also are bipotent till 9 weeks. It is at 9 weeks, under the influence of testosterone and dihydrotestosterone, which I will discuss again in detail. 9 weeks pe jaake the differentiation towards the male internal genitalia happens. Okay, otherwise by default, the embryo, the genitalia looks female till 9 weeks. Under the presence of androgens, that the external genitalia will develop into the male external genitalia, and in the absence of testosterone, it will develop into the female external genitalia. So remember, gonads are bipotent till 5 weeks. Internal genitalia, that means both Mullerian and Wolffian duct coexist till 8 weeks, and external genitalia is bipotent. That it means it can go either way at till 9 weeks. 9 weeks pe jaake it gets decided if it's going to be male or it's going to be remain female. Okay, now moving on, let's first discuss the first type. The embryo is 46XY. Okay, so it's a 46XY embryo. इसमें क्या होगा? The SRY gene is going to be present. So what is the gonad going to be? The gonad is going to be the testes. ठीक है? Now the testes has two types of cells. It has the Leydig cell and it has the Sertoli cell. जैसे female में granulosa theca cell था, यहाँ पे Leydig and Sertoli cell. The Leydig cell is going to secrete testosterone. Okay, and the testosterone is going to convert the Wolffian duct into the male internal genitalia. क्या क्या बनता था Wolffian duct से? Remember, seminal vesicle, vas deferens and epididymis. ठीक है? So this is what the Wolffian duct is going to differentiate into under the influence of testosterone. ठीक है? Sertoli cell, one more thing, the testosterone also gets converted to another hormone called dihydrotestosterone. And this conversion happens by which enzyme? Which enzyme will convert testosterone to dihydrotestosterone? Yes, 5-alpha reductase. Okay, and this dihydrotestosterone is responsible for the male development of the male external genitalia and also the prostate gland. Okay, so male, Himanshu, you are right, but we're talking about the embryo. So remember, ये जो testosterone levels होते हैं, ठीक है, ये दो टाइम बढ़ते हैं in a individual. One is during embryonal development. एक बार ये सब differentiation हो जाए, the testes become dormant and then they start producing testosterone again at puberty. So one is during the embryonal life they're active and then they become active again at puberty. So you're completely right. He's saying secondary sexual characters be develop karte hai, but not in the embryo. Otherwise the embryo will be born with a mustache and a beard. Hai na? So that happens again at puberty. Okay. Now Sertoli cells, what do? Sertoli cells are going to secrete AMH. What is AMH? AMH is anti-Mullerian hormone. Okay. And it's also called as Mullerian inhibiting substance. Same thing. Okay. What does this do? The name itself is telling you AMH, anti-Mullerian hormone. तो Mullerian duct को गायब कर देता है. It's going to cause disappearance of the Mullerian duct. Okay, so this is what is happening in the male embryo. In the male embryo, because it's 46XY, the gonad is going to be the testes. The testes has two types of cells, the Leydig cell and the Sertoli cell. Okay, the Leydig cell secretes testosterone. This is responsible for differentiation of the Wolffian duct into the seminal vesicle, the vas deferens, and the epididymis. The testosterone also gets converted to dihydrotestosterone, and this is responsible for the differentiation of the male external genitalia into the penis, the scrotum, the typical male external genitalia, and also development of the prostate. ठीक है? Sertoli cell क्या करता है? Sertoli cell secretes anti-Mullerian hormone. And anti-Mullerian hormone is going to cause disappearance of the Mullerian duct. तो Mullerian duct गायब हो जाएगा. Wolffian duct is going to grow, okay, and develop. So this Wolffian duct differentiation starts taking place at 8 weeks, and the male genitalia starts taking place at differentiation starts. This is the starting. It starts taking place at 9 weeks. And this determinant of the gonad ki kya banega, this starts taking place at 5 weeks. MIS is Mullerian inhibiting substance. It's the other name for anti-Mullerian hormone. Okay, so this is what's happening in the male embryo. Okay, so now what's happening now? Before we go to the female embryo, try to understand what is happening in androgen insensitivity syndrome. AIS में सब बन रहा है, ठीक है? Testosterone बन रहा है, DHT बन रहा है, AMH बन रहा है, but this testosterone is of no use because it's not acting. So what happens? Wolffian duct fails to develop. So there is no male internal genitalia. Similarly, the 5-alpha reductase DHT is also not working. So there is no male external genitalia. It follows the default pathway, that is the female. Also, Sertoli cell, however, is working, right? And AMH is working. It's only the androgens that are insensitive. सो AMH बन रहा है तो क्या हो जाएगा, मुलेरियन डक्ट गायब हो जाएगा. सो यू हैव एन इंडिविजुअल who has testes as the gonads, who is 46XY, who is having testes as the gonad, but even though testosterone levels are normal, nothing else is, it's not working. So कुछ भी नहीं बन रहा, ना testes बन रहा है, sorry, ना vas, seminal vesicle, epididymis, prostate, nothing is formed. ठीक है, and it looks like the baby is born looking like a female. And also, this person doesn't have a uterus because the AMH is forming, but the AMH is, and the AMH is acting. So there is no uterus. There is disappearance of the Mullerian duct. I will explain again when we talk about disorders of sexual differentiation. So don't worry. I thought I'll cover this topic partly here. The basics, थोड़ा सा और detail में जाएंगे in another half an hour. So just bear with me. Okay. What's happening in the फीमेल 46XX में क्या हो रहा है, तो ये 46XY में हो रहा था. 46XX में देर इज नो SRY जीन. देर इज नो SRY जीन मीन्स द गोनैड दैट फॉर्म्स इज द ओवरी. ठीक है, सो दिस इज हैपनिंग एट 5 weeks. The ovary, the gonadal sex is now the ovary. Now what does the ovary secrete? The ovary doesn't have to secrete anything, nothing. Okay, so women don't need anything, right? Women are superpowers. They don't need, like, not like men. Men need everything to develop. Women don't need anything. Ovary कुछ नहीं करेगा, बस ovary है. ठीक है, अब testosterone नहीं है. There is no testosterone, so the Wolffian duct will degenerate. ठीक है, there is no AMH, so what's going to happen? The Mullerian duct is going to grow. And again, because there's no testosterone, the female external genitalia is going to be female because that's the default pathway. Female ही लगता है, वो female ही develop होगा. So this is literally what's happening in the embryo. If the gonad is the ovary starts functioning only at puberty. उससे पहले dormant रहता है. But क्योंकि testosterone नहीं है, AMH नहीं है, तो ये सब जो male में हो रहा था, nothing happens. Okay, and the embryo by default is going to develop as the female, and because there is no AMH, the Mullerian duct is going to grow and develop nicely. Okay, so this is what's happening. Now, now coming back to AIS. Let's discuss AIS one more time so you understand better. It's an X-linked recessive disorder. There is abnormality in the androgen receptor. So because of this abnormality in the receptor, although testosterone levels are normal, nothing develops. So this is a person who is born looking like a female, who presents with primary amenorrhea at puberty with breast development. This is an important point because this testosterone is not acting otherwise, but some amount of peripheral conversion of androgens does happen, and this estrogen causes breast development. But there is no pubic or axillary hair which are androgen receptor dependent. Okay. Now, when you diagnose this, how will you diagnose this? This girl will come, when you examine her, she looks like a female, but there is no axillary, there's hair, there's no pubic hair, and there is an abnormality. And when you do a karyotype, you find this, they are 46XY. Also remember, they don't have a uterus. So that's the most important thing. So if you get a person who's having secondary sexual characters present, okay, the most important thing you should look for is, do they have a uterus or they don't have a uterus? If they don't have a uterus, then you are left with two possibilities. या तो वो AIS है या MRKH है. ठीक है, how will you differentiate between both? By the karyotype. So karyotype is very important in differentiating between MRKH and androgen insensitivity syndrome. Yes, Jayasurya, this patient will have testes. Gonads will be testes. So when you do an ultrasound, you will find gonads in the inguinal canal. They will be undescended because there's no scrotum. They will have undescended testes. Okay, and so when you do a biopsy of the gonads, you will find testicular tissue. That is why in management is very important. In management, whenever you have a 46XY individual, you have to do a gonadectomy because these dysgenetic gonads have a 20% risk of malignancy. They are somebody's asking, why is external genitalia female? Because testosterone is unable to act on the receptors. So male external genitalia doesn't develop, and default pathway is of that of a female. ठीक है. So gonadectomy has to be done. They require intensive psychological counseling. They are usually reared as women. They've been brought up all their life as women. And most of them will continue to be wanting to be as a female. So they already have breast development. They don't require additional estrogen. Because usually breast development is complete by that time. Gonadectomy is required and a vaginoplasty is required because you need to give them a significant vaginal length. Also remember that can they get pregnant? They can't get pregnant. So AIS can never get pregnant. So no pregnancy is possible in AIS because they neither have ovaries nor do they have a uterus. Okay. So pubic hair will not develop because their receptors are not sensitized. They will have breast development. They won't have pubic. अच्छा है ना, pubic hair नहीं है, pubic hair axillary hair नहीं होगा. ठीक है. Okay. External genitalia female hoga बच्चे लक्ष्य, but remember the upper part of the vagina which is formed by the Mullerian duct is not going to be there. So the vagina is going to be very short. It's going to be very, very short. Okay. Sperm will be there, but the gonad, it will not go anywhere. The gonads anyway have to be removed. So the gonadectomy will be done. Now coming to another small top part which is important to understand called partial AIS. Now ये जो partial AIS है, इसमें the name itself tells you that there is partial androgen insensitivity. मतलब some receptor sensitivity is there. Okay, so they are going to present somewhat midway, and partial AIS usually presents either they are born with ambiguous genitalia, or depending on the amount of receptor sensitivity, or at puberty what happens, androgenic features start developing, but not to a large extent. So androgenic features start developing. Okay, this could be commonly what we describe, if you want to ask a question, is clitoromegaly. Okay, or maybe facial hair increases, hirsutism. Okay, these are usually typical features. So at puberty, androgenic features or features of virilization start happening because testosterone starts increasing at puberty. And this testosterone is not able to act fully, but some amount of activity is there. So the typical thing they will ask in the exam is clitoromegaly. That means the clitoris will start enlarging. Clitoromegaly, by definition, is a clitoris which is more than 1 centimeter in length, is the definition of clitoromegaly. Okay. Yes, the testes will be abdominal. On scan, you will find a gonadal looking structure, okay, which looks like an undescended testes, but they have to be removed. Gonadectomy has to be done because there's a 20% risk of malignancy in these undescended gonads. Okay, so this is what's happening in AIS, partial AIS. Another extreme form of AIS is something called as Riefenstein syndrome for the INI-CT people. Isme it's even so very, so it's again it's AIS only, but it's again a component of partial AIS where this is going to present as a male. Everything will be male, but because they have little bit androgen insensitivity, they are going to present with male infertility. Usually testicular is, the sperm, oligospermia will be there, or azoospermia. Partial AIS is also treated like a female. Yes, partial AIS. So partial AIS, again, it depends a lot on the presentation. If the genitalia is ambiguous at birth, this again requires a lot of intensive counseling for the parents. A lot of proper work has to go into this. But remember, it is always easier to make a person a female compared to make a person a male. It's always easier surgically, okay, to convert the genitalia to female than to make it a male. So usually whenever you have ambiguous genitalia at birth or a person at puberty developing clitoromegaly, the plastic reconstructive surgeries are easier if you want to make them female compared to male. Okay. This is Riefenstein syndrome. Riefenstein syndrome is another extreme. So on one extreme you have complete AIS, the other extreme you have Riefenstein syndrome. Okay, so these patients will have, because of testosterone insensitivity, androgen insensitivity is there, they will present usually with male infertility, usually with oligospermia. Okay. So now coming back to primary amenorrhea, we're going to discuss this again in detail and some more time. Okay, but let us first discuss now the compartment 2 problems. Compartment 2 problems में क्या था? Compartment 2 problems में था problems with the ovary. So you have a patient with primary amenorrhea and the problem is in the ovary. So this group of patients is basically referred to as gonadal dysgenesis. Okay, that is, the problem is in the ovary. Better than ovary, I will say the problem is in the gonad. Okay, so there's abnormal development of the gonads, and as a result, will the secondary sexual characters be present or absent? So a person who has a compartment 2 or ovarian problem, yes. So they are going to present with primary amenorrhea with absent secondary sexual characters, because the problem now lies at the level of the gonad. There is no estrogen. So estrogen levels are less, and that in turn results in a positive feedback. So FSH, LH levels are going to be high. So this is referred to as hypergonadotrophic hypogonadism. Okay, so hypergonadotrophic, because the gonadotropes, the FSH, LH are high, and hypogonadism, estrogen level is low. So hypergonadotrophic hypogonadism is seen when the problem lies at the level of the ovary or the gonad. The most common type of this is Turner syndrome. So Turner syndrome is an individual who is 45XO. This is the most common. What are the other types? You can have pure gonadal dysgenesis. This basically means a 46XX karyotype with gonadal dysgenesis, with the ovary not functioning. Or you can have a 46XY gonadal dysgenesis. Anybody can tell me what is the name of the 46XY type of gonadal dysgenesis? Yes, Swyer syndrome. Now इस पे questions बहुत आते हैं, Turner's पे भी आते हैं, इस पे भी आते हैं, but इस पे they like asking questions on Swyer syndrome. Now come back to this slide, ठीक है? Swyer syndrome में क्या हो रहा है? Swyer syndrome is a 46XY person, ठीक है? So SRY gene is positive, is present, so the gonad is the testes. But this testes, this gonad is dysgenetic. This gonad is not functioning. That means there is no testosterone and there is no AMH being secreted, right? It's just the tissue, the microscopic appearances of a testes, but it is dysgenetic. It is a gonad which is not functional. Despite being 46XY, despite being the gonad being the testes, they are dysgenetic. So they're not functional. So Leydig cell is not secreting anything. There is no testosterone. So there is no male internal genitalia. There is no male external genitalia. Similarly, there is no Sertoli cell secreting AMH. So there is no AMH. So there's no AMH means, will there be a uterus or there won't be a uterus? Yes, there will be a uterus, correct. So uterus is going to be present. Okay, so in Swyer syndrome, one second, in Swyer syndrome, which is a type of 46XY gonadal dysgenesis. In your workbook, you'll find this in some pages later, but let me just explain it here. In Swyer syndrome, in 46XY gonadal dysgenesis, you have an individual who is 46XY, but the gonad is the testes, but it is not functional. It is dysgenetic. Dysgenetic का मतलब वो नहीं काम कर रहा है. ठीक है? Testes नहीं काम कर रहा है. That means there is no testosterone. That means there is no male internal genitalia because there is no testosterone. Also, there is no male external genitalia. Okay, and there is no AMH means what's going to happen? The uterus is going to be present. So Mullerian duct is going to develop. So you have a 46XY individual with a uterus. So whenever you encounter this scenario, 46XY with a uterus, okay, this means this is Swyer syndrome. Okay, and what is important about all these gonadal dysgenesis, whether it is Turner's, whether it is Pure, whether it is Swyer, what are you going to do for them? How will you manage them? You need to give them estrogen, okay? And if they have a uterus, they will all have a uterus, you give them progesterone also. So estrogen and progesterone are going to develop the secondary sexual characters, and they're going to develop the uterus, and she's going to get her period if you're giving her estrogen plus progesterone both. Okay, so the management is estrogen plus progesterone in all types of them. In addition, in Swyer syndrome, you're also going to do a gonadectomy. You're going to remove the gonad because this can lead to malignancy. Okay. AIS and 46XY and Swire is also 46XY. How will you differentiate? The Jasvi is asking, can anybody tell me what is the most important thing? Uterus kisme hoga, kisme nahi hoga? AIS mein uterus is going to be there. Swire mein uterus is going to be, sorry, AIS mein uterus is going to be absent. Swire mein uterus is going to be present. That's one primary difference. Second difference, AIS mein breast development is going to be there. Swire mein there is no absent secondary sexual characters. Okay, so AIS and Swire both are 46XY, okay, but both have completely different presentation. Primarily, secondary sexual characters are going to be present in AIS, especially breast. Swire mein kuch nahi hoga. Uterus will be absent in AIS, uterus will be present in Swire. Okay, uterus, correct, Niroj. In Swire, DHT is absent, so external genitalia is going to follow the default pathway. There is no male external genitalia. Default pathway is female. So female genitalia will develop. Okay. I can't give a break in the middle of a topic. Okay, so Priyanka, I need to finish a topic, otherwise you lose the consistency. Now coming to Kalman syndrome. Kalman syndrome is now, so now we've gone straight to compartment 4 problem. That means the problem is in the hypothalamus. Why did I skip compartment 3? Because there is no significant important disease of the pituitary which causes primary amenorrhea. Pituitary problem causing secondary amenorrhea hai. Which problem in the pituitary can cause secondary amenorrhea? Sheehan, correct. So compartment 3 से मैंने skip किया है, but remember pituitary problems, although rare, can happen. Okay, but they are more important for secondary amenorrhea. Kalman syndrome kya hai? Kalman syndrome is hypothalamic cause. That means there is reduced GnRH leading to reduced FSH-LH. Okay, leading to reduced estrogen and progesterone. So it's basically a cause of hypogonadism. Okay, so that's important. FSH-LH भी कम है, so hypogonadotrophic. Estrogen progesterone कम है, so hypogonadism. And typical about Kalman is its association with anosmia. Also, cleft lip, cleft palate, cerebellar ataxia, and sensory neural hearing loss can also be there. Primary amenorrhea is the rule. The ovaries are small because they're not functional. FSH, LH, estrogen, everything is less. What is the management? Again, you're going to supplement with estrogen and progesterone. Anosmia, yeah, Ruchi, anosmia is there. Compartment 3, Dhanush, is Sheehan, but Sheehan causes secondary amenorrhea. So when we will discuss secondary amenorrhea, remember the same compartments आएंगे, ठीक है? Causes different हो जाएंगे. So there is no significant pituitary cause of primary amenorrhea, but of secondary amenorrhea. ठीक है? So whenever you have primary amenorrhea with anosmia, always think of Kalman syndrome. Okay. Now these two flowcharts are very important. Okay, this is going to help you answer some questions. We're going to understand these two flowcharts. Then we're going to talk a bit about evaluation of secondary amenorrhea. Then we're going to do a lot of questions. Okay, and then we take a 5-minute break. Okay. So those of you asking for break. Okay. Now, coming to this flowchart, if you get a question in the exam, the first thing you need to see, but Harsh, I need to take a small 5-minute break, but only after we finish this topic. So, normal secondary sexual characters. So, the first thing you see if you get a question on primary amenorrhea, सबसे पहले देखो कि उसका एज क्या है. It might not even be in the definition. It might be just an anxious patient. So always seek the age. Does it fit into primary amenorrhea? And also see the secondary sexual characters present hai ya absent hai. If it's fitting in the definition of primary amenorrhea, see whether secondary sexual characters are present or not. If they are present, what is the change the arrow please. The next best step is what? The next step you're going to do is look for the presence or absence of a uterus. That's the next thing you're going to do. Okay. How will you do that? Either by doing an examination, but of course the best way is to do an imaging and see कि uterus है या नहीं है. अगर uterus है, suppose the uterus is present. So patient has come, say she is 15-year-old, secondary sexual characters are present. You examine her or you do her ultrasound says the uterus is present. Then ask, look for history, कहीं पे outflow में obstruction तो नहीं है. Is she having cryptomenorrhea? Is she having abdominal mass? Is it an imperforate hymen? Is it a transverse vaginal septum? But if the uterus, if the outflow tract is also normal, then think of that it could be normal. Everything could be completely normal, constitutional, or maybe it is, then you start thinking of other things like early PCOS, which is again rare, or a hyperprolactinemia. Okay, so where prolactin levels go high. And these are more important causes of secondary amenorrhea, but rarely they can present as primary also. So basically, agar sab normal hai, then most likely it is constitutional. Give her some time, she will get her period. But if the uterus is absent, this is the most important thing. If the uterus is absent, then you think of either MRKH or AIS. How can you differentiate between both? Why will Swire be here, pretty doctor? Pretty doctor, Swire में the secondary sexual characters are going to be absent. अभी हम बात कर रहे where secondary sexual characters are normal. And if the uterus is absent, you will think of 46XX or 46XY. Depends. So basically, depending on the karyotype, you will see whether it is MRKH और एंड्रोजन इनसेंसिटिविटी सिंड्रोम. ठीक है. MRKH में दोनों में यूट्रस एब्सेंट होगा. MRKH में द gonad is the ovary, AIS में the gonad is the testes. So most of the times we do a karyotype, but some questions I have seen, not in the exam, but I've just seen other questions which have come, and there they have done a gonadal biopsy. So they may, instead of giving you the karyotype, they may even give you a clue that a gonadal biopsy was done and it shows ovarian tissue or it shows testicular tissue. So you can differentiate based either on karyotype or on the basis of a gonadal biopsy. But gonadal biopsy is invasive, so we usually don't do that. We usually do a karyotype and that clears the difference. ठीक है? Yes, correct. Pretty doctor, स्वायर में भी uterus होगा तो वो तो इस flow chart में आएगा ही नहीं. ठीक है? 1 second, Veram, let me continue this. Another very important difference is AIS में you will be typically, they will give you this history most of the time that pubic and axillary hair are absent. So look for this clue also in the question. Okay, somebody just wants to see this slide. Vera Milo. Gonadal biopsy, Avneet. Gonadal biopsy. So either we do a karyotype or we do a gonadal biopsy. Okay, biopsy. And we see the tissue, whether it is testicular or ovarian. But a much easier, non-invasive, and what we clinically do is a karyotype. Okay, now come to, because pubic and axillary hair are androgen dependent, receptors nahi functional honge, so pubic axillary hair are going to be absent. Now coming to absent secondary sexual characters. Now again, please change the arrow. If the question comes that secondary sexual characters are absent, so you have a 13, 14, 15, whatever year-old girl above the age of 13 with absent secondary sexual characters, the next thing, look in the question ki uska height, is it given or not? Why is this important? Because whenever they mention typically short height, remember short height is the sine qua non of Turner syndrome. What do you mean by sine qua non? Just I don't know how to pronounce it, but this is Latin for everybody has short height. Sine qua non ka matlab it is the compulsory feature. Every yes, always present. All Turner girls are going to be short. Baki coactation of aorta, streaked gonads, shield-like chest, webbing of neck, and the cubitus valgus. That may not be there in all Turners, but all Turners are going to be short. Okay, somebody saying right in capitals. I'm really sorry. Short height is the sine qua non of Turner syndrome. So, as soon as you read this word short height, alarm bells should start ringing कि ये Turner's होगा. ठीक है, फिर भी we need to confirm. Okay, so how do we confirm? Confirm between what? Because if it's a hypothalamic, a complete hypothalamic lesion or a complete pituitary lesion, that can lead to growth hormone deficiency, and that can also lead to short height. So we still need to be very careful and look for more clues in the question. So a very important differentiating factor कि whether the problem is lying in the ovary or in the hypothalamus or pituitary is by doing an FSH level. If the FSH level is high, that means the problem is in the ovary. That means it is Turner syndrome. Okay, so a FSH, a high FSH level, the problem is going to be in the ovary. That means hypergonadotrophic hypogonadism. Remember that term, है ना? But if the FSH is low, that means the problem is in the hypothalamus or the pituitary. Okay, how short should the height be, Yutika? So usually an average girl, they would mention specifically short because again, it depends. It's very age dependent and population dependent. Okay, but anything less than 145 centimeters, है ना, would be short in height for a girl who is 15 to 16 years old. Okay. Next comes normal height. Normal height, maybe we need to now differentiate. So basically, when there's absent secondary sexual characters, in simple terms, the problem is in the HPO axis. Right. And we need to know whether the problem is in the hypothalamus pituitary or is the problem in the ovary. And the best way to differentiate this is by doing the FSH. Okay, FSH high hai, the problem is in the gonad or ovary. Okay, this could be XX, we've ruled out XO lesions, 45 XO. So it could either be a pure gonadal dysgenesis or Swyer syndrome. And if the FSH is low, the problem is in the hypothalamus or pituitary. A common condition I've written here is isolated GnRH deficiency. So this is how you differentiate between in questions. So always look for secondary sexual characters. That's your first thing, first clue. Okay, and if it's absent, that means the problem is in the HPO axis. The next thing you need to look for, if it's a short height, which is a very big clue, it could be Turner's. If that is not given, look for the FSH value. FSH high hai problem in the ovary, FSH low hai problem is higher up. Okay. Now coming to, because we are on this topic, before we go for questions, I want to quickly discuss secondary amenorrhea ka evaluation also. Okay, previous slide here. Okay, now secondary amenorrhea means absent period for more than 6 months. What is the most common cause of secondary amenorrhea? Very good, Prem. It is pregnancy. ठीक है, तो अगर क्वेश्चन आता है unmarried 18-year-old girl comes with absent periods, you, even if she's unmarried, you have to rule out pregnancy. Pregnancy is the most important and most common cause. So being married is not a criteria to get pregnant. That is just to confuse you. Okay, so most common cause is not Asherman's. Most common cause is pregnancy. Okay, what are the other causes? So once you've ruled out pregnancy, the first thing you need to do is do a UPT. Okay, once you've done a pregnancy test, next, you have to rule out two important things. One is a thyroid disorder, which is again a very common cause of menstrual complaints, and another is pituitary. ठीक है, so thyroid and pituitary causes have to be ruled out. Sorry, not pituitary, my mistake, my bad. Prolactin. So hyperprolactinemia is another very common cause of secondary amenorrhea. So rule out thyroid disorders, rule out hyperprolactinemia, and primarily rule out pregnancy. Once you've ruled out these three, pregnancy, thyroid, prolactin, then what do? We give this patient a progesterone challenge test. So a patient comes with secondary amenorrhea. The most important thing is we give the patient a progesterone challenge test. What does this mean? We give her progesterone. Tablets are available, progesterone tablets. We give the tablets for 7 to 10 days and then we ask her to wait for a few days. She will get her period or she doesn't get her period and then she comes back to us. So if she has bleeding with the progesterone challenge test, इसका मतलब क्या है? इसका मतलब ये है कि progesterone was deficient. Dose of progesterone is not important. If she has, the concept is important. If she bleeds with the progesterone, what does this mean? This means that progesterone was deficient. And where do we see progesterone deficiency? We see it in an ovulation. Ovulation नहीं है तो corpus luteum नहीं बनेगा, corpus luteum नहीं बनेगा तो progesterone नहीं होगा. And the most common cause of anovulation in the reproductive age group is polycystic ovarian syndrome. ठीक है, so think on the lines of PCOS. But suppose she has no bleeding, she doesn't bleed with the progesterone challenge. Then what do? Then we give her a estrogen plus progesterone challenge test. Okay, so estrogen plus progesterone, what do? We usually give 10 to 15 days of estrogen plus 10 to 15 days of progesterone, or we just simply give the combined contraceptive pill, which has both estrogen and progesterone. Okay. So why do we give estrogen and progesterone? Because agar progesterone se wo bleed karti hai, we know that the problem is deficient progesterone. Suppose she bleeds with estrogen and progesterone. Bleeding, that means we know that estrogen is also deficient. The problem is if you have given her estrogen and progesterone and she bleeds with it, that means estrogen was also deficient. Now, where could the problem be? If estrogen is deficient, the problem could be anywhere in the HPO axis. So how do we differentiate कि problem hypothalamus pituitary पे था या the problem was in the ovary? We again do an FSH. If the FSH levels are high, the problem is in the ovary. So what problem can you think of in the ovary, which will lead to secondary amenorrhea other than PCOS? PCOS to rule out ho gaya. Yes, premature ovarian failure. That means premature menopause. That's why the ovary isn't functioning. She may be a 30-year-old woman who has reached menopause. Okay, that is premature ovarian failure for whatever reason. है ना? And when you evaluate her, you find that estrogen or progesterone देने से bleeding हुआ है. That means estrogen is also deficient. So we do an FSH. Remember, in menopause, FSH goes high. Similarly, in premature menopause, what will be your inference? The problem is in the hypothalamus or pituitary, and a common cause we think here is Sheehan syndrome. So think of stuck. Is it better now? Okay. Where did I get cut off? Okay, so if the FSH is low, then the problem is in the hypothalamus or pituitary, and here the common thing we think of is Sheehan syndrome. So look for clues. What is Sheehan syndrome? Sheehan syndrome typically the the thing. Okay, stuck again. 1 second. I will rejoin. Wait. Okay, is it better now? Can you hear me? Okay. So coming to Sheehan syndrome, what is Sheehan syndrome? Okay, so if the FSH is less, and when I say FSH is less, FSH is more, you should know normal FSH values. Normal FSH values are between 1 to 10. These are normal values. Less than 1 is low, more than 10 is high. Okay, this is because I've seen questions where they've just given the value. So you should know normal FSH values. Now, what exactly is Sheehan syndrome? शीहैन सिंड्रोम में क्या होता है? शीहैन सिंड्रोम में there is basically pituitary necrosis. Why does pituitary necrosis happen? One of the most common predisposing factor is following postpartum hemorrhage. Why after PPH will the pituitary undergo necrosis? Anybody? So following, so pregnancy में क्या होता है? Pregnancy में all the organs in the body, the blood supply increases, right? है ना? Everybody knows this. Why pituitary में क्यों होता है? और किसी organ में hypoxia क्यों नहीं होता PPH में? Why only the pituitary? Have you ever thought about this? So the pituitary, what happens is that in PPH, in pregnancy, all the blood flow to all the organs is increased in proportion to the increase in blood volume in pregnancy. But pituitary बेचारा वो वाला organ है जिसमें blood flow नहीं increase होता. It is the same. So it is very sensitive to even a little bit amount of blood loss. It undergoes necrosis. So PPH में जब ज़्यादा blood loss होता है, it undergoes necrosis and it undergoes apoplexy. So all the pituitary hormones go down. Am I still lagging or is it okay? Wait, let me just change my connection again then. Little lag is there. ठीक है, okay, it's fine. So following PPH, there is going to be pituitary necrosis and all the pituitary hormones go down. So you're going to have reduced prolactin leading to failure of lactation. You're going to lead to reduced FSH and LH leading to secondary amenorrhea. You also end up with thyroid disorders. You also lead to generalized fatigue, weakness, okay, and a lot of other symptoms. So this is what the typical presentation will be. Jagdish, it's usually after PPH because I just told you PPH may every other organ is fine, but pituitary ka blood supply doesn't increase in proportions. It's one of the first organs in the body where the ischemia happens. Okay. So this we were coming to bleeding hota hai by giving estrogen progesterone. The cause could be in any part of the HPO axis. FSH is going to help us determine where the problem is. And if there is no bleeding on giving estrogen progesterone, that means the problem is where now? So you've given estrogen progesterone, you've given, and she doesn't have bleeding. That means the problem is in the uterus, correct? The problem is in the uterus. So what uterine causes secondary amenorrhea? Correct. It is Asherman syndrome. So just write down this slide for those of you who are writing this down. Then I'll show you this slide because some of you want to see this slide. And I will start writing about Asherman syndrome in the next slide. Okay. So in Asherman syndrome, what is happening? In Asherman syndrome, you have basically intrauterine adhesions. And why does this happen? This forms because of a damaged endometrium. And why does the endometrium get damaged? Because of two reasons. Either you've done a vigorous curettage. For example, patient had come with a incomplete abortion or an inevitable abortion, or she had an MTP and you've done a evacuation, and then you've done a after the evacuation you have done a vigorous or a very rough curettage and all the endometrium is damaged. Very right, Anukriti, overzealous curettage. ठीक है कि basal layer of endometrium भी you have destroyed. Okay. Or another common cause which came in this year's NEET PG, they gave a scenario of secondary amenorrhea which did not bleed on estrogen progesterone, and then they gave a laparoscopic image of something. Anybody has seen that question? No, so another common cause is genital tuberculosis, especially in our country. Okay, where there is chronic endometritis. So there is damage to the endometrium, which is a chronic damage. This chronic endometritis leads to intrauterine adhesions or synec and leads to Asherman syndrome. So Asherman syndrome can be seen in both scenarios. Okay, and what is the diagnosis or the investigation of choice for Asherman syndrome? Is a hysteroscopy. No need for laparoscopy. It is a hysteroscopy. Okay, and what is the treatment of choice? You can treat it at the same setting. You do a hysteroscopic adhesiolysis. That is, you break up all the synec or you cut all the synec, and once you cut all the synec, it can again, fibrosis can happen, it can again rejoin. So what we usually do is we put in a barrier, we put in an intrauterine device for 3 to 6 months. We also give estrogen so that the endometrium nicely develops again. And then what do? We do a redo hysteroscopy just to see that the adhesions are still separate. So we usually do this 3 to 6 months later. Okay, so this is what is under complete treatment, hysteroscopic adhesiolysis, and then you have to keep a barrier so it doesn't fibrose again. So we usually put a copper T or any intrauterine device, and then we give estrogen also to rebuild the endometrium. And then after 3 to 6 months, we do a redo hysteroscopy. And if again adhesions have formed, we cut up those adhesions again. Okay, so this is the complete treatment of Asherman syndrome. 1 second, I have to take a call. आईयूडी कब तक बचे? 3 से 6 महीने तक ना, उसके बाद you will do a redo hysteroscopy. That is not important. You just should know the concept. You put an intrauterine device and then a redo hysteroscopy is done. Okay, now let us do some PCOS. I'll be discussing in infertility. So this is going to be discussed there, not in infertility, sorry, not here. So just let's wait on this topic and let's do the questions. Take a small 10-minute break and then get back. Okay, so this is INI 2021 question. Match the correct condition with the karyotype. The answers I've given you already, but let's just go through it. Remember that जहाँ पे अगर ये सब भूल जाओगे है ना, एग्जाम तक अगर रिवाइज नहीं करोगे, just remember जहाँ पे y है ना, that is 46xy. So even if you forget everything, just remember wherever there's a y, that is 46xy. Previous slide, sorry, 1 second. Those of you who are still writing. This one? Gursharan, this one or the one before? This one? Or this one? Which one? Batao to say which one? No response. Okay. Acha, before this. This one. What is written above hysteroscopy? Koi batao what is written above hysteroscopy? I don't know which one she's saying. What is written above hysteroscopy is investigation of choice. Okay. Coming to वर्कबुक में जगह नहीं है तो एक एक्स्ट्रा पेज लगाओ. वैभव, इसका भी सोल्यूशन मैं बताऊं. Just put an extra page. You're writing or you have your iPad. If you have an iPad, add a page. If you have a notebook, just add an extra page. पीछे extra pages है. Okay. In life, just general advice to everybody. In life, general life advice, whenever you encounter a problem, okay, rather than cribbing or thinking ये क्यों है, ये क्यों नहीं मिला मुझे, ये क्यों नहीं हुआ. Always try to find a solution. Okay, this is general life advice because I see a lot of students saying कि ma'am this is missing, that is missing, और ये नहीं हुआ, वो नहीं हुआ. Always try to find a solution. ठीक है, see we are not all perfect, we are all human, after all to err is human, है ना. uh, but we all want to benefit from life, है ना. Nobody wants to not benefit from life, है ना. You want to make the fullest use of what's given to you. And if you find deficiencies, or if you find obstacles in life, I told you, na, life is a game of snakes and ladders. You won't just sit at the bottom of the snake and not move forward again, है ना. और crib की मुझे snake क्यों मिला है. My son does that when we play snakes and ladders, ना, he's 7 years old. तो वो बहुत गुस्सा होता है when he's playing snakes and ladders. उसको snake मिलता है, he starts crying, he starts throwing a tantrum. But gradually he's learned. When he was 6, now he's 7, now he's better. So he knows कि ना ladder भी मिलेगा. So find ways to overcome obstacles instead of sitting at that obstacle and wondering कि ये क्यों नहीं मिला मुझे. Just general, this is not for this is just general life advice. You kids are very small. I told you I'm very old, so this is just general advice which I have learned over the years. Okay. Coming back to this question, ठीक है. तो Swire में Y है, androgen insensitivity में Y है, so 46XY. Turners हम बचपन से पढ़ रहे हैं, this is 45XO, we all know this. And MRKH is 46XX, ठीक है. Which is not, this is also, so in INI 2021, there were so many questions on amenorrhea. I think 5-6 questions were there, which is not a cause of secondary amenorrhea. ठीक है. The answer is Kalman. Kalman always causes primary amenorrhea. Turner mosaic क्या होता है? Turner mosaic means half the cell lines are 45XO and half the cell lines are 46XX. So this patient doesn't have completely streak ovaries. They have some follicles in the ovaries. She will have a few cycles, maybe a few years of periods she'll have, but then she will end up in premature ovarian failure. ठीक है. Then you have fragile X premutation. What is fragile X premutation? This is also one of the causes of premature ovarian failure. Just remember that if a person has the fragile X premutation, it can cause premature ovarian failure. And Sheehan syndrome, we all know will cause secondary amenorrhea. Okay, it doesn't cause primary amenorrhea. So these are all causes of secondary amenorrhea, not of primary amenorrhea. Okay, a 16-year-old girl presents to the gynae OPD with complaints of primary amenorrhea. She has a female phenotype and her height is 150 centimeters, which is normal. ठीक है? She has poorly developed breasts. So which flowchart are we looking at? We're looking at the second flowchart. Second flowchart कौन सा था जिसमें absent secondary sexual characters थे? ठीक है? On further evaluation, a vagina was present. Ultrasound reveals a normal uterus, but gonads were not seen. That's because they're small. In gonadal dysgenesis, you may not be able to visualize the gonads on any imaging. Investigation shows high FSH and the karyotype is XY. So this is telling you, in fact, a better answer would be that this is Swire syndrome. But Swire, we know, is a type of gonadal dysgenesis. It is a type of 46XY gonadal dysgenesis. So Swire will have a uterus, but the gonads are dysgenetic. And because the gonads are dysgenetic, they're not functional. What's going to happen? Estrogen will be less and FSH, LH are going to be high. So this is what is gonadal dysgenesis. Yes, so Senapati, good question. Can Swire become pregnant? Yes, Swire can become pregnant, but not using her own ovaries. She has a uterus. So you can use her uterus, but she will require donor oocytes. That means she has to borrow somebody else's oocytes, and then with IVF using her husband's sperm, embryo is formed and that embryo is transferred into her uterus. Why not see? Kalman में FSH क्या होगा? Ashwarya, what will happen to FSH? It's a hypothalamic problem in Kalman. FSH is going to be low. If Kalman or hypothalamic disorders will be hypogonadotrophic hypogonadism. Also, Kalman will be 46XX. ठीक है? An 18-year-old, it's not kind of surrogacy, Sandhya. Surrogacy का मतलब होता है uterus, you're borrowing someone's uterus. This is donor oocyte. You're borrowing someone's oocytes. Okay, like donor sperm. In azoospermia, what do we do? Vicky donor देखा है ना? So donor sperm. इसमें we can also borrow someone's oocytes. An 18-year-old girl presents with primary amenorrhea. On evaluation, she was having a karyotype of 45XO and an infantile uterus, a small uterus, because estrogen nahi hai. So what should be done next? You have to give her, I told you, estrogen. So HRT means hormone replacement therapy. In simple terms, it is estrogen plus progesterone. Okay, so HRT we use commonly in the menopausal age group, the term, but it's also used whenever you want to say estrogen plus progesterone. Yes, this is Turner syndrome. No, in Turner's, you won't do gonadectomy. Remember, gonadectomy you will do only when there is a 46X. Don't need to do a gonadectomy anywhere else. A young female presents with primary amenorrhea. Examination reveals normal breast development and absent axillary hair. So this itself is telling you कि ये क्या हो सकता है ना? It could be androgen insensitivity syndrome. Pelvic examination shows a normally developed vagina, but there is clitoromegaly. So is this complete AIS or partial AIS? This is partial AIS. Complete AIS will have completely normal looking female genitalia. Okay, this is a AIMS 2019 question. Okay. Investigations for primary amenorrhea in a girl with full development of secondary sexual character should be performed by what age? By the age of 15. If they were absent, then by the age of 13. Okay, so definition itself can come as a question. What are the FSH LH levels in Turner syndrome? Turner's में क्या होगा? Estrogen कम है. So FSH, LH are going to be high. It's going to be hypergonadotrophic hypogonadism. Whenever the ovaries are involved, the FSH, LH is going to be high. Which of the following should be the next investigation in a patient present? These are all these questions. There are some 15 questions. All are previous 5-year questions. Okay, none of them are my own made up questions. Which of the following should be the next investigation in a patient with primary amenorrhea and normal secondary sexual characters? Yes, it should be an ultrasound. So the next thing that you're looking when, this is our first flow chart. When secondary sexual characters are present, the next best thing is to do an imaging or examination and look for the presence or absence of a uterus. Previous question. Turner's में क्या होता है? Gonadal dysgenesis or streak gonads, right? So that means the ovaries are streak. They are not formed. So estrogen is less and this will cause a positive feedback on the hypothalamus. ठीक है? 16-year-old girl with well-developed secondary sexual characters and ovary as the gonad. However, the uterus is absent. Okay, so they've given you the gonad is the ovary. So whenever the uterus is absent, I told you think of two things, MRKH and AIS. Okay, and to differentiate between them, either the karyotype will be given or a gonadal biopsy. Here they've mentioned that the ovary is the gonad. So this is MRKH syndrome, also called as Mullerian agenesis. Remember, testicular feminizing syndrome, I forgot to tell you this, is the other name of androgen insensitivity syndrome. So AIS का दूसरा नाम है TFS, testicular feminizing syndrome. Mullerian agenesis is also called as MRKH syndrome. ठीक है? 24-year-old woman is being evaluated for amenorrhea. You order a hormonal profile, which is the correct match. So let's start with this. This is a nice question. Premature ovarian failure. What will you find? It is like menopause. So FSH is going to be high. Estrogen, what's happening to estrogen? Estrogen is going to be low. So you have low estrogen and FSH is going to be high. So where is that option? You have the first option only. Hai na? FSH, LH, both are high. So FSH, LH go together. Okay, estradiol is going to be less. Asherman's mein everything was normal. Remember, the problem is in the uterus. HPO is normal. The HPO axis is normal. So everything normal. PCOS में क्या होता है? Is there any particular hormonal feature you look for in PCOS? Yes. What is the typical feature you find in PCOS? You find that the LH becomes more than FSH. Normally कितना होता है? Normal FSH and LH values both are between 1 to 10. I told you, no, both are between 1 to 10. LH also is between 1 to 10. FSH also is between 1 to 10. And normally the FSH to LH ratio is 3 is to 1. But in PCOS, this becomes ulta. It becomes 1 is to 3. That means the LH becomes more than the FSH. Okay, so this is what you find in PCOS. And Sheehan syndrome, pituitary failure. Pituitary failure means FSH, LH are going to go down. Estrogen is also going to go down. So everything is going to be less. Okay. Estrogen is not high in PCOS. Estrogen levels will be normal. Okay, estrogen is normal. Progesterone deficiency hota hai, so it becomes a hyperestrogenic state in a relative term. ठीक है, estrogen is not being opposed by progesterone, so estrogen acts uninhibited on the endometrium. Okay, I know what you're trying to say, Sheetal. It's not a hyperestrogenic state per se. It does lead to uninhibited estrogen because there is no progesterone. In secondary sexual characters, Prashant, we include everything, ठीक है? But AIS में specifically breast development होता है, pubic axillary hair नहीं होता है. Okay, which would be defined as primary amenorrhea. A girl presenting with not attaining menarche with age and breast tanner staging of what? So let's look at the scenario. Suppose a girl comes at age 11 and there is no breast development. Are you worried? No, you're not worried. Why are you not worried? Because you can wait till the age of 13 years. है ना? Age 14, tanner stage 1. Are you worried? Yes. By 13 years, secondary sexual characters should have developed. है ना? Then age 12, tanner stage 4. Are you worried? Are you not worried? Just hold on a second. Okay. Age 12, tanner stage 4. Are you worried? No, you're not worried because 13 years tak this should have developed. Age 13, tanner stage 5. Are you worried? Are you worried or not worried? You can wait till 15 years. So you're not worried again. You're only worried in this no secondary sexual characters. By age 13, you will start evaluation. Okay. 16-year-old girl is seen for primary amenorrhea. She has development of breasts but no hair in the pubic or axillary region. Her height is normal, weight is normal. She has bilateral inguinal masses. On ultrasound, the uterus, fallopian tube, and ovary are absent. What is the most likely diagnosis? This is complete AIS, है ना? Ovary नहीं है, ovary की जगह क्या है? You have inguinal masses which are most likely to be the testes, that is the gonads. ठीक है? And she doesn't have a uterus. There is no pubic axillary hair. Everything is pointing towards complete androgen insensitivity syndrome. In which of the following statements will you suspect primary amenorrhea? This was the INI, multiple options correct. Okay. Failure to attain menarche by age 15 is correct. So irrespective of secondary sexual characters are there or not, the upper limit is 15. Failure to attain menarche even after 3 years of thilarc also. Okay, this is also there. High level of TSH and short stature is not a definition of primary amenorrhea. Okay. Failure of development of breasts by 13 years of age again becomes a definition. So A, B, and D are your primary amenorrhea के proper definitions. Okay. This was your NEET PG morning session. Okay, a 25-year-old woman whose last delivery was 5 years back presents with secondary amenorrhea of 2 years. She does not bleed on giving estrogen and progesterone. A laparoscopy shows the following. तो क्या दिख रहा है हमें? Uterus दिख रहा है और क्या दिख रहा है? Can you see these whitish lesions on the uterus? These are miliary tubercles. So they have given you a clue that this is a patient with genital tuberculosis. She has a uterine cause of amenorrhea because she's not bleeding on giving estrogen and progesterone both. And the clue they've given here is genital tuberculosis. Okay, so this is not Asherman. If Asherman was also an option, the better one would still be genital tuberculosis. Okay, because Asherman causes genital tuberculosis. I mean, genital tuberculosis is a cause of Asherman's. Another cause is a vigorous dilatation and curettage. This is also morning session question. Scenario was given. I don't the exact scenario I don't know, but it was primary amenorrhea with secondary sexual characters present, uterus and ovary present with image as shown. So this was basically an image of imperforate hymen, and the answer is 46XX. Okay. So that is about amenorrhea, a very important topic. You can see many questions will come in the exam. And now we come to, again, we've discussed this, but I just want to again put this across, and then we take a break, I would suggest. Okay. So this is, ये already हम कर चुके हैं discuss, but this is just over a few slides. We will just go through it again. ठीक है, इसमें I'm just going to read the slide, and you can understand better now because you have the basics. So what happens in normal sexual differentiation is the main thing that is going to determine it is the presence or absence of the SRY gene, which is on the short arm of the Y chromosome. This is the first important thing. Okay. Now coming to this timeline, remember 4 to 6 weeks likha, so you can basically remember 5 weeks. At 5 weeks, this differentiation of gonads is happening. That is, the primordial germ cells migrate to the genital ridge to form the bipotent gonads. And at 5 weeks, the determinant happens that, yeah, we'll have just one break, that is the dinner break, correct? And then we will continue. I think that's fine. Okay. Now, I told you this also, you have a common Wolffian duct, okay, and a Mullerian duct. The Wolffian duct, remember, is also called the mesonephric duct. And the Mullerian duct is called the paramesonephric duct. It's the same thing. Wolffian is mesonephric, Mullerian is paramesonephric. Remember, M और M साथ में नहीं आता, ठीक है, अलग अलग होता. So Mullerian is paramesonephric, Wolffian is mesonephric. ठीक है. And how I remember, not to offend any of the men here, I remember that men are like wolves. Not to offend any of them. Again, I apologize beforehand, just to remember. Yes, men are wolves, Anukriti. All the girls, I think, remember like this. You know? So men are wolves, that's how you remember. Okay? Sorry, guys, again. Okay, now the external genitalia looks like this in the embryo. Okay, it's a complement. Okay, that's good. So you have a genital tubercle, you have urethral folds, and you have labioscrotal swelling. So this is how the external genitalia in the embryo looks like. So it looks like a female. So if nothing, there's no testosterone, this will develop into a female looking embryo. Okay. Now let's start with XY. XY में क्या हो रहा है? There is an undifferentiated gonad. The primary gene responsible is the SRY. There are two other genes. If you want to, you can remember, but don't forget the SRY gene. SOX9, WT1 भी होते हैं, but primarily is the SRY. This is going to determine that the gonad is going to be the testes. ठीक है? फिर क्या होता है? I told you there are two cells. You have, I think, Leydig cell वाला slide गायब हो गया इसमें, पता नहीं क्यों. You have a Leydig cell and you have a Sertoli cell. Leydig cell is going to secrete testosterone. Sertoli cell is going to release AMH. And this causes regression of the Mullerian duct, which is by 8 weeks. Okay? So the Wolffian duct will differentiate into the epididymis, the vas, and the seminal vesicle. High local concentration of testosterone stimulates the ipsilateral. So दो testes होते हैं. This testes will differentiate ये वाला Wolffian duct. ये testes will differentiate ये वाला Wolffian. So it depends on the ipsilateral Wolffian duct. ठीक है? So thus duct differentiation proceeds according to the nature of the adjacent gonad. So same thing, what's happening here? In the male, you have this developing epididymis, vas, seminal vesicle. In the female, you have the uterus, the vagina, the uterus plus the cervix. Oviduct is the fallopian tube. Okay? So same thing again and again. repeating. This is important. In the external genitalia, the genital tubercle forms the penis in the male, it forms the clitoris in the female. Okay, so the genital tubercle forms the penis in the male, the clitoris in the female. The edges of the urogenital sinus form the penile urethra, and the labioscrotal folds form the scrotum in the male, and in the female, they're going to form the labia majora. Okay. If serum testosterone, Jagdish, वही मैं बता रही हूँ, the testosterone is normal, but the receptors for the androgen, that means both testosterone and DHT are not functional. So वो testosterone है, but वो काम नहीं कर रहा है, तो इसलिए nothing develops. Okay. So testosterone gets converted to DHT by the enzyme 5-alpha reductase. ठीक है. And these are highly sensitive to dihydrotestosterone, but the receptors should act na tabhi to they will develop. Okay, PCOS we'll discuss in infertility, Shashank, don't worry. So this is what happens in the male. Now this flowchart is for the male. So let's go through this again once. So at 5 weeks, the gonad formed is the testes. The Sertoli cell starts functioning around 6 to 7 weeks, and the Leydig cells start testosterone production around 8 weeks. So at 8 weeks is when the internal genitalia starts developing into male and the Mullerian duct starts disappearing. Okay. So this process happens, completes between 9 to 12 weeks. It starts at 8 weeks. At 9 to 12 weeks, this develops. 9 weeks पे क्या start हो जाता है? 9 weeks पे start होता है external genitalia. So again, just remember 5 weeks, the gonads are bipotent. 8 weeks, the internal genitalia is bipotent, and 9 weeks, the external genitalia is bipotent. इसके बाद the differentiation starts. ठीक है? It's the same thing again and again. Now, if it's XX, what happens? It's a bipotent gonad. There is lack of SRY. This suppresses the SOX9 gene. And there are two other genes in the ovary. Although we primarily say it is because of lack of SRY, but recently two genes have been found which are responsible for differentiation of the gonad to the ovary. If you can remember this for the INI, the WNT4 and the RESPO1 gene. Okay, but primarily is the lack of SRY. Okay. So what's happening here? There is no Sertoli cell, no AMH, development of Mullerian duct. Okay. The Mullerian duct will differentiate into the things I told you: uterus, cervix, fallopian tube, upper part of the vagina. तो ये सब लिखा हुआ था, ठीक है? So you can just go through this whenever you have time. Same thing happens. What I told you, the female will develop. External genitalia में the genital tubercle remains small. This forms the clitoris. The margins of the urogenital sinus form the labia minora. The labioscrotal folds form the labia majora. And the urogenital sinus, so margins hai, they form the labia minora, and the main urogenital sinus forms the lower vagina and the urethra. Okay? Upper vagina comes from the Mullerian duct. Lower vagina comes from the urogenital sinus. Okay? And then both of them fuse. If they don't fuse, that results in a transverse vaginal septum. Okay? So this is what happens in the female. So the default path is the female. If there's no testosterone, it's going to look like a female external genitalia. Okay? Now coming to disorders. Now this topic I discuss in detail in the INI classes. Okay, but here I'm just going to tell you the classification, because individual disorders we have anyway discussed many of them in detail. This is the old classification. ठीक है, and ये important इसलिए because INI 2021 में एक question आया था इस पे. ठीक है, but now we follow this complicated looking new classification. It's complicated looking, it's not complicated. The old classification, we call these people as hermaphrodites. ठीक है, so you have two types of hermaphrodite. You have true hermaphrodite and you have pseudo hermaphrodite. How is this class like a marathon? I have spent almost 2.5 hours on this topic. Sai Krishna, this is like a normal class, है ना? True hermaphrodite, in fact, I usually take this topic in 1.5 hours. But I think this is the same with every subject. Every faculty has been telling me this कि थोड़ा ज़्यादा time लग रहा है because a lot of you guys are new. It's okay. We don't mind spending more time, है ना? But ये मत बोलो कि marathon class है. ठीक है, so true, I'm ignoring, don't worry. True hermaphrodite has both ovarian and testicular tissue. ठीक है, so you have either one side there is a testes, one side the ovary, ये भी possibility होता है. ठीक है, और both the gonads have both ovarian plus testicular tissue, ऐसे भी possible है. क्यों होता है? There are many reasons, many genetic reasons. We won't go into the details of why this happens. But in a true hermaphrodite, you basically have a person who has both ovarian and testicular tissue. When we say pseudo hermaphrodite, it could either be male or female. So what are we at? When we say male pseudo hermaphrodite, we're basically talking about the gonad. If the gonad is the testes, but this person looks like a female, okay, we will call it a male pseudo hermaphrodite. But and female pseudo hermaphrodite is this person has ovaries but has masculine genital characteristics. Okay, so when I say male pseudo hermaphrodite, that male refers to the gonad, testes hai but looks like a female, and female pseudo hermaphrodite has ovaries but looks like a male. So male pseudo hermaphroditism ka example would be like your AIS, है ना, or your Swyer syndrome. These would come under male pseudohermaphrodite. They have testes, but female looking genital phenotype. And female pseudohermaphrodite has ovaries. Okay, these are people who have, say, testicular tumors, virilizing tumors, ovarian tumors, which are producing testosterone, or congenital adrenal hyperplasia. Things like that would present with having ovaries but appearance of a male. Okay, so this is what you should know. Question jo aaya tha, they had given an example. You know which example it was? What is this kind? Was it AIS or Swire? कुछ पूछा था कि ये कौन सा type of है? Is it a true? Is it a male? Is it a female pseudo hermaphrodite? So pseudo hermaphrodite, Yutika, exactly why you don't know. So these are people who are born either with ambiguous genitalia, or they come in the pubertal period and they are confused about the sex because the testes, the karyotype is showing something like we have just discussed. And so many we've discussed already. No, bache, this picture is not important. Okay, this picture is this hermaphrodite term has come from Greek mythology, है ना, तो इसलिए मैंने दिखाया. So there was a very handsome, very extremely good looking man called Hermes. Hermes या Hermes, I don't know how you pronounce it. Hermes का वो bags आते हैं ना, वो देखा है ना, कौन सी मूवी थी? जिंदगी ना मिलेगी दोबारा, है ना, फिर हमीज का बैग लेके घूमता है. यस, सो this beautiful Hermes, yes, Hermes, probably H is silent, so जैसे भी pronounce करते हो, Bhagwati, है ना. So he was an extraordinarily looking beautiful man. Okay, and there was a nymph. Okay, nymphs होते हैं fairy like creatures in Greek mythology. Her name was Aphrodite. ठीक है, and she fell in love with his appearance, or she fell in love with him, and she prayed to the gods that we have to be together, we have to be one, है ना. So the gods took her prayers very literally, कि we have to be one, so they fused them together, है ना. So Hermes and Aphrodite were fused together, and hence the term hermaphrodite came from this Greek mythological term. So an extraordinarily beautiful looking person, but couldn't make out whether male or female. Okay, so that is where this terminology has come from, for those who wanted to know more about it. Okay, but the picture is not important. Yeah. Okay, now coming to the new classification. अब हम confuse करेंगे थोड़ा सा आपको. The new classification is basically based on genetic sex. ठीक है, it's based on the genetic sex. That means if a patient comes to you who is looking like a hermaphrodite or has a difference in features versus karyotype, you are going to classify them based on their karyotype. Is their karyotype 46XX? Is it 46XY? Is it a different other than 46XX, 46XY? ठीक है. Okay, Krishna has told something else, which I told. You've written that Hermaphroditus was the child of Hermes and Aphrodite. I thought it was the fusion of Hermes and Aphrodite, not their child. Maybe I am mistaken. I'll also have to read through that again. So the water nymph fell in love with Hermaphroditus, not with Hermes. ठीक है, maybe I'm wrong, but you got the gist, na? कि exactly क्या हुआ था, that is what they've written. ठीक है, anyway, coming back here. 46XX disorders of sexual differentiation में क्या आएगा? So you basically divide them based on their karyotype. ठीक है, now based on the karyotype, the ones I've written in red, these are the ones which you should have some idea about, like MRKH syndrome जो हम discuss कर चुके हैं. Another important one is congenital adrenal hyperplasia. Now CAH is the most common cause of ambiguous genitalia at birth. And I do not know, but I think it should be discussed in pediatrics and maybe medicine. Okay, but if not, it's an important area from INICT. But I am not discussing it here because I think it would have been discussed in endocrinology in either pediatrics or medicine. Has it not been covered? Let me know. Okay. So MRKH syndrome we have discussed. ठीक है, remember ये जो है ना testicular DST, ovotesticular D, these are true hermaphrodites. So true hermaphrodites can be of any karyotype. ठीक है, but most commonly they are 46XX. This is not important for NEET PG. I've already told you ना 46XY में हम Swire discuss कर चुके हैं. Two other important types are 5 alpha reductase deficiency, which I have told you a bit about, and 17 alpha hydroxylase. What you should remember in 5 alpha reductase, what is very important to remember in 5 alpha reductase, I told you testosterone gets converted to dihydrotestosterone by the enzyme 5 alpha reductase. ठीक है, so this is not getting converted, so DHT levels are going to be low and testosterone levels are going to be normal. So the diagnosis or the investigation of choice in 5 alpha reductase deficiency is a T to DHT ratio. If this ratio is going to be high, it is diagnostic of 5 alpha reductase deficiency. Okay, this is what you should know about 5 alpha reductase. How do they present? They again present with ambiguous genitalia either at birth or at puberty. Okay, and the investigation of choice is the T to DHT ratio. Because DHT levels are less, the T to DHT ratio is going to be high. Okay, then another one we've discussed, complete AIS we've discussed. Turner and Klinefelter, you already know enough about. Okay, so basically this is the new classification. The new classification is as per the karyotype of the person. Okay,